Hello, my name is Megan Nicola, and today we will be discussing Lydia Hall's Care Core Cure model. So, Lydia Hall, education wise, she first got her nursing degree in 1927. She then went on to get her Bachelor's of Science in Public Health Nursing in 1932. In 1942, she went on to get her master's degree in teaching, and then she pursued a doctorate program and completed all the requirements except for her dissertation. So, career wise, she started her career at a life insurance company that focused on preventative medicine. She then was a staff nurse at two different hospitals. She then became a professor, teaching nursing the importance of being a part of a healthcare team. She was also a research analyst focusing on cardiovascular disease. And then lastly, she was the founder and first director of a nursing and rehabilitative center. So Lydia's interest in research started as rehabilitative nursing and the role that registered nurses played in patients' recovery and welfare. She authored 21 publications and various articles regarding long term care and chronic disease control. She observed hospital care, which made her realize the value of nursing to patient welfare. Upon this observation, she saw that nursing care was fragmented. Patients often felt depersonalized, and patients, physicians, and nursing were all concerned about the poor quality of nursing care. They argued that hospital beds need to be grouped into units that focused on delivering a therapeutic nursing and opposed the concept of team nursing. She saw nursing care as there is nothing simple about patients who are complex human beings, or a nurse who is also complex, who finds herself involved in the complexities of disease and health process in a complex helping relationship. Lydia was convinced patient health outcomes are improved when direct care is provided by a primary nurse. She then divided the phases of care being two phases. The first one is the patient is in crisis and they're in need for intensive medical therapy. Phase two, the crisis is over, the patient is stabilized, and the patient is in need of different forms of therapy. So, the theory to look and to listen to self is often difficult without the help of a significant figure who has learned how to hold up a mirror and sounding board to invite the behavior to look and listen to himself. If he accepts the invitation, he will explore the concerns in his acts, and as though he listens to his exploration through the reflection of the nurse, he may uncover the sequence, his difficulties, the problem areas, his problems, and eventually the threats which are dictating his out of control behavior. So, this theory has multiple different concepts. The first being the individual. The individual must be of 16 years of age and is past the acute stage of long term illness. It is important that the individual is viewed as unique, capable of growth and learning, and requiring a total person approach. We then have the health, which is a state of awareness with conscious selection of behaviors that are optimal for the individual, assisting to help the individual explore the meanings of their behaviors to identify and overcome the problem through developing self-identity and maturity. Then we have society and environment. Hospital environments during the treatment of acute illness creates different psychological experiences for the ill patient. Focus on providing an environment that is conducive to self-development, assist the patient to create a home environment that will help the individual obtain their personal goals. And then lastly, we have nursing, identified as a constant in the care, core, cure aspects of patient care. Spiritual care and spiritual love are intrinsic qualities in a nurse to patient relationship. This care and love comes from the heart and results in one relationship with God, and patients can perceive these qualities positively and sense that they're being taken care of and valued. So, for this theory to work, there are some assumptions, including the motivation and energy necessary for healing exists within the patient rather than the healthcare team. Three aspects of nursing should not be viewed as independent, but interrelated. And then the three aspects interact. The circles representing them can change in size depending on the patient's total course of progress. So the actual care core cure model is three aspects of the patient. The first, the core, being the person. Second, care, being the body. And last, cure, being the disease. So care, nursing is concerned with intimate bodily care, including comfort measures, patient instructions, helping patient with their needs and maintaining a healthy environment. They develop an interpersonal relationship with the individual that will facilitate the development of the core. The core, therapeutic use of self, emphasis on social, emotional, spiritual, and intellectual needs, the patient in their relation to their family, institution, community, and world. Patient sets their own goals and behaves according to their feelings and their values, and they can make their illness a learning experience. Lastly, the cure is related to nursing from physician orders, attention given to patients by medical professionals, and this is shared by all healthcare professionals. So, relationship to theory, the core care cure model focuses on giving the patients the tools and resources to be in their own health advocate, and then they become a key player in their healthcare team. This model can be utilized in the primary care setting for various diseases, and the three interlocking circles may change in size and overlap in relations to the patient's phase of their disease process. So, for example, we have Jim. He's a 65-year-old male that comes to the clinic for a sick visit, believes he has an upper respiratory infection, endorses shortness of breath, cough with brown sputum, weight gain, swelling. We diagnose him with a new onset heart failure, and he is sent to the ER for evaluation. So during this heart failure exacerbation at the clinic, at the ER, when he's admitted, we are using this model to be very cure-based. Procedures may include labs, echo, cardiac catheterizations, thoracentesis, medications like diuretics, blood thinners, antihypertensives. We are just trying to stabilize Jim, because if he isn't stabilized, we cannot focus on the core or care. And then Jim comes back to the clinic after he's been discharged from the hospital. He's doing great. All of his symptoms have resolved, and his heart failure is under control. So at this visit, it needs to be very care centered. This is a new disease for the patient, so we need to educate them on disease process, medications he'll be taking, his diet, his heart failure log, including a daily weight, and his food restrictions. Educating the patient can then create him being his own patient advocate at his core, and he can decide what he wants to contribute to his health. And then on top of the cure, which includes medical management, and symptom relief. So, in comparison, based on where the patient is health wise, can create different needs and different requirements based on the care core cure model. And then those are my references, and thank you.